Welcome to the deep dive. So, we had a request to really get into the weeds on a specific sign, purpura. If you're prepping for the MSRA, this is definitely one of those high-yield topics you need squared away. We're going to walk through the key source material, pulling out the must-knows.
Exactly. The aim here is to filter out all the noise and just highlight the core facts, the differentials you need on your radar, and the key management points, just the essentials for revision.
Okay, then let's unpack this. Starting right at the beginning, what exactly is purpura?
Well, fundamentally, purpura refers to those, noticeable purple or reddish spots. You see them on the skin, sometimes on mucous membranes too. They can look a bit like bruises.
Right. And why do they actually appear? What's happening?
It boils down to bleeding,
Hmm.
bleeding into the tissues just under the skin surface. And that happens because there's an issue with either the blood vessels themselves or the platelets, the little cells that help clotting, or the whole coagulation system.
So it's a visual sign that there's bleeding where it shouldn't be. And there's a key distinction about size, isn't there?
Yes, absolutely. And it's good terminology to have. The really small spots, we're talking less than a centimeter, they're called petechiae.
Mm.
When you get larger areas, more like a typical bruise, those are ecchymoses.
Yeah.
Purpura is sort of the umbrella term for both.
Okay.
And it's so important to remember, it's a sign. Yeah, it's like a warning light indicating an underlying problem.
Right.
It's not the disease itself.
Yeah.
And yeah, it can pop up inside the mouth or nose too,
Hmm.
on those mucous membranes, even potentially in internal organs.
Got it. Purple spots, signals bleeding, small are petechiae, large are ecchymoses. Always points to something underlying vessels, platelets, or clotting. So what kind of things cause it? What does the source material flag up?
The causes are pretty wide-ranging, actually, which is why it's such an important sign to recognize. The source groups them into categories like immune disorders, think vasculitis, where vessels get inflamed. Infections and meningococcal is highlighted as, a really critical one.
Like the urgent one.
Definitely. Then you've got platelet problems, maybe not enough platelets or they aren't working properly. Coagulation disorders, where clotting is impaired. Certain medications can trigger it. Other underlying medical conditions, and sometimes, even just straightforward skin trauma.
That's quite a list already. Are there specific causes we really need to nail down, maybe thinking about kids versus adults?
Absolutely. This is prime revision territory. The source really emphasizes a few key ones. For children, you absolutely must have meningococcal septicemia top of mind. That's a medical emergency. Also, ALL, acute lymphoblastic leukemia, can present this way.
Okay.
For adults, things like ITP, immune thrombocytopenic purpura, where the body attacks its own platelets, bone marrow disorders affecting platelet production, drug reactions, sometimes even nutritional deficiencies.
And the source draws a line between issues due to low platelets versus other problems, right? Thrombocytopenic versus non-thrombocytopenic.
Yeah, that's a really useful distinction. Thrombocytopenic means the purpura is happening because the platelet count is low. That could be because the bone marrow isn't making enough zinc bone marrow failure, or because they're being destroyed too quickly, like an ITP, or used up, like a DIC, disseminated intravascular coagulation.
Which is that systemic clotting chaos.
Exactly. Now, non-thrombocytopenic purpura happens when the platelet count is actually normal. So here, the problem lies either with the blood vessels, maybe they're fragile or inflamed, like in vasculitis, or Henoch-Schönlein purpura, which is a specific type of allergic vasculitis, or there's an issue with the coagulation factors themselves, the proteins needed for clotting, like in hemophilia.
That difference feels key for working through possibilities later. So who's generally more likely to develop purpura? What are the risk factors?
Well, the risk factors are really tied to those underlying causes we just talked about. Generally speaking, the source points to things like advanced age, having other conditions like autoimmune diseases or liver problems. Remember, the liver makes clotting factors.
Right.
Also being on medications that affect clotting, like anticoagulants or even some antibiotics. And of course, having a known history of bleeding disorders or platelet issues.
It also mentioned normal purpura occurrences. What's that about?
Ah, yes, that's an important nuance. Basically, not all purpura is immediately alarming. The source mentions things like everyday bruising, which just happens sometimes, maybe more often in women, and specifically senile purpura in older adults, those darkish patches you often see on the backs of hands or forearms, often after minor bumps.
Okay.
They can look quite dramatic and last for weeks. But the key thing is usually the person has no other bleeding problems, and their platelet count and clotting tests are completely normal. It's more about skin fragility.
So context is key, especially with older skin. Could you just quickly recap the basic mechanism again, the pathophysiology?
Sure. So at its heart, It's blood leaking out of the tiny blood vessels, the capillaries, into the surrounding tissue, like the skin. And that leak happens either because the vessel wall itself is damaged or weak, or because the normal plugging mechanism, platelets sticking together and clotting factors kicking in, isn't working right.
Right.
So the fault could be the vessel, the platelet number, platelet function, or the clotting proteins. Which one depends entirely on that underlying cause we discussed.
Makes sense. So if someone comes in with purpura, what else might be going on that looks similar? What are the key differential diagnoses?
Right, this is where you need a broad perspective because, as we said, purpura is nonspecific. The source lists quite a few, obviously simple bruising from an injury. Erythema multiforme, which is a skin reaction, can sometimes look a bit purpuric.
Okay.
Then there's Hanoch-Schönlein purpura, that's specific vasculitis.
Yeah.
You need to think about coagulation disorders like hemophilia, serious bacterial infections, meningococcus, but also strep or even diphtheria, DIC, that systemic clotting problem we mentioned.
Route.
Also, long-term steroid use can thin the skin, making purpura more likely. You can get low platelets after blood transfusion sometimes. There are also chronic skin conditions, pigmented purpuric dermatoses, even things like amyloidosis or factitious purpura where someone causes the lesions themselves. It's a huge range from relatively minor to life-threatening.
That really drives home why you need to investigate properly. How common is it overall? What's the epidemiology look like?
Yeah, the source notes that it's actually quite hard to pin down a single number for the UK. Because it's a symptom of so many different things, its overall prevalence isn't tracked as purpura. The frequency really depends entirely on the specific cause. So ITP has its own known incidence, but that doesn't tell you about purpura from, say, trauma or infections.
Right. So focus on the epidemiology of the causes.
Exactly. Don't get too bogged down trying to find one overall statistic for purpura itself.
Okay, makes sense. Let's imagine someone presenting them. We see the spots. What else are we looking for? What questions do we ask? How does the history and examination guide us?
Well, the appearance itself gives clues. Are they tiny petechia or bigger ecchymoses? Are they spread out everywhere or just in one area? Do they merge together? Are they confluent? Are there blisters? Is it just skin or inside the mouth too? The distribution can be really telling.
And other symptoms.
Yes, absolutely. Look for associated symptoms, red flags like fever, joint pain, any bleeding from elsewhere like gums or nosebleeds. And importantly, feel the lesions. Are they flat or are they raised, palpable? Palpable purpura often suggests inflammation in the vessel walls, like you see in vasculitis.
Okay. And what about the specific things to cover in the history and examination?
Key things for history. Age is crucial, remembering those different common causes in kids versus adults. Ask how long the rash has been there. Has it changed? How does the person feel overall? Are they generally unwell? Any history of easy bruising or bleeding before any recent travel. And always get that full medical, allergy, medication, and social history. Then on examination, inspect the rash really carefully. Size, how they're grouped, any blisters, where they are. Definitely check mucous membranes. And gently feel them. Are they tender? Tenderness often points towards inflammation.
And the source really hammers home the point about acting fast here.
Absolutely. It explicitly states that early recognition and evaluation are critical, especially when you're thinking about something like meningococcal septicemia that can progress incredibly rapidly. Delay is just not an option if that's on your differential.
That feels like a really crucial takeaway. Okay, so after the history and exam suggests purpura, how do we pin down the actual cause? What investigations are typically needed?
It's a logical process, really, starting from your clinical suspicion. The source outlines the standard approach. Good history, good exam, then targeted lab tests. The absolute basics you'll almost always need are a full blood count, the FBC, crucial looking at the platelet count. Then you need to assess coagulation, so a coagulation screen, and often markers of inflammation like an ESR or CRP.
Are there other specific tests mentioned?
Yes, depending on the clinical picture. Things like liver function tests, LFTs, are important if you suspect liver disease affecting clotting, and INR if they're on warfarin, maybe plasma electrophoresis or autoantibody screens if you're thinking about autoimmune conditions.
Okay.
And sometimes you might need more specific things like a skin biopsy, maybe imaging. But the key message is that the clinical scenario drives the tests. So if infection is high on your list, particularly something like meningococcal disease, then blood cultures and potentially a lumbar puncture become essential investigations.
Right. Tailor the test to the patient and your suspicions. So once you have a likely cause, what's the approach to management?
This is probably the most important principle the source emphasizes. Treatment depends entirely on the underlying cause. There isn't a treatment for purpura itself. You absolutely must identify and treat the specific condition causing it.
So antibiotics for infection, immunosuppression for autoimmune disease, etc.
Exactly. Address the root problem.
Are there any general supportive things we can do?
Yes. The source mentions some simple supportive measures. Things like rest, elevating the affected limb if possible, maybe compression stockings in some cases, particularly if it's related to leaky vessels in the legs. These can help reduce further bleeding or swelling.
And there were some critical platelet count numbers we need to remember for urgent action.
Yes, absolutely vital for exams. The source flags these clearly. A platelet count below 30, that's 30 by 109 per liter, suggests a serious risk of significant bleeding. Below 20 requires urgent treatment, which might involve platelet transfusions or other specific therapies, depending on why the count is low. Remember, 30 serious risk, 20 urgent action.
Got it. Less than 30 risk, less than 20 act now. Any other key management points?
Yeah, a couple really important ones. Firstly, in children presenting with bruising or purpura, especially if it seems unexplained, you must do a full examination, including the anogenital area, to consider non-accidental injury. That's crucial. Secondly, if you strongly suspect a serious underlying bleeding disorder, you should avoid giving intramuscular injections, as they can cause large, deep bruises or hematomas.
And what about that simple bedside test?
Ah, yes, the glass test or diascopy. It's a quick, useful clinical tool. You press a clear glass firmly against one of the spots. If it's true purpura caused by blood that's leaked out of the vessels, it won't blanch, it won't fade under pressure. If it's just dilated blood vessels, like in some other rashes, it will blanch. Helps confirm you're dealing with actual extravasated blood.
Classic clinical check. Okay, so finally, what's the outlook? What's the prognosis usually like, and what complications can occur?
Well, as you'd expect by now, the prognosis is entirely dependent on the underlying cause. If you can treat the cause effectively, the purpura itself will usually resolve. But if it's due to a more serious or chronic condition, the prognosis is obviously more guarded. Following the treatment plan for the underlying issue is key for the best outcome.
And potential problems down the line.
Complications mentioned include things like recurrent bleeding episodes, which could eventually lead to anemia. Infection is also a risk, either as part of the illness or due to treatments that might suppress the immune system. Long-term, any complications usually relate directly back to that underlying disease. For example, the source specifically notes that vasculitis-related purpura can cause organ damage if it's not controlled properly.
So it always circles back to identifying and managing that root cause.
Absolutely. The source really finishes by stressing that prompt diagnosis and management are just essential, not just to clear up the spots, but really to prevent those serious complications and lessen the impact of whatever underlying condition is driving it.
Well, that brings us to the end of our deep dive into purpura based on this material. We've gone from the basic definition through that wide range of causes, how to investigate, and the principles of management.
It's quite something, isn't it? How a simple visual sign like skin spots can open up such a huge differential, from minor issues right through to genuine emergencies, really makes you think systematically.
It certainly highlights how crucial it is to look closely, ask the right questions, and remember that what you see on the surface is often just the beginning of the story.
And just a reminder for your revision, for more free MSRA resources, you can visit freemsras.com, and for the full premium revision toolkit, head over to passthemsra.com.
Thanks for joining us for this deep dive. We hope that was a helpful tour through the key points on purpura for your MSRA prep.